მკურნალობაში აქ ატარებენ კონსულტაციებს და შემდეგ თუ ვინმე სჭირდება აქ ვეხმარებიან და თუ არა და მიდიან მათ ქვეყნებში. ასევე ხდება ჩვენთან რეზიდენტების, ექიმების კურსები, ვისაც სჭირდება გადამზადება პრაქტიკა, მათი დაკვალიანება და რომელ ქვეყანაშიც ჭირდებათ, ვეხმარებით იქ მოიძიონ შესაბამისი კლინიკები, სადაც შეძლებენ ამ პრაქტიკის გავლას. დღეს ერთ-ერთი ჩვენი ესეთი ვიზიტორი კლინიკაა ინდოეთში, ძალიან ცნობილი აპოლო ჰოსპიტალი, რომელსაც აქვს პროტონოთერაპია და დღეს წარგვიდგენენ ამის შესახებ მოხსენებას გააკეთებს თვითონ ქსელის გენერალური მენეჯერი და ამის შემდეგ თვითონ პროფესორი, რომელიც უშუალოდ პროტონზე მუშაობს. ვთხოვ ახლა მათ რომ Okay.
Good morning, everyone. I am Gaurav Thakral from Apollo Hospitals, New Delhi, India. To begin with, I would really wish to thank all of you to come on this Saturday morning and join us for this session. After that, I would really want to thank Ms. Ika to give us this opportunity to come and speak in front of you. Today, I'm joined with Dr. Srinivas Chilikuri, who is the Senior Consultant for Radiation Oncology from Apollo Proton Cancer Center, and Mr. Amit Garg from AS Medical Linkers from India. So today, the objective of this meeting is to introduce to you about Apollo Hospitals and about the services that we offer, and especially about the Apollo Proton Cancer Center and the proton beam therapy, which is much required and is the latest technology in treatment of many typical cancers. To begin with, it's a brief presentation I will give to you about Apollo Hospitals. There was a small video which was going on. I am certain you must have looked at it, which was giving a brief idea about what Apollo Group is. The objective of Apollo Hospital is to bring the healthcare of international standards within the reach of every individual. We are committed to the achievement and maintenance of excellence in education, research, and healthcare for the benefit of humanity. That's our mission. Just to give you the idea about the Apollo legacy, as you can see, we have right now 75 tertiary care hospitals across India, in almost every major city of India, with more than 10,000 bed capacity. So far, we have touched more than 90 million lives, and patients from 141 countries have already visited Apollo hospitals for their treatment. So far, we have done more than 200,000 heart surgeries, over 40,000 joint replacements. I really feel proud to share that the first ever liver transplant in children was done at Apollo hospitals in India. We have done so far more than 4,500 liver transplants. The first multi-organ transplant, that was the liver and the kidney transplant, was also done at Apollo Hospital, India. We have done more than 19,000 kidney transplants. That makes us the busiest solid organ transplant program in the world. This is how one day looks like across Apollo Hospitals Group. We have more than 140,000 patients visiting us every day. In a single day, we end up doing more than 60,000 laboratory tests, more than 3,000 emergency cases, more than 2,200 admissions, that means IPD admissions every day. 800 CT scans are done in one day. 400 MRIs are done in one day. 900 dialysis sessions in one day. More than 800 major surgeries in one day, more than 40 cardiac surgeries in one day, and 3 to 4 organ transplants, the solid organ transplants. So the blueprint of Apollo Hospital is essentially the clinical excellence that we have, the doctors that we have, the medical expertise that we have. Number 2 is the tender loving care, because every patient that we bring in, we treat them as our family member. And the third thing is the cutting edge technology. Proton is one such example, the latest of the technology that we use. The fourth is essentially the cost benefit. The fifth one is the academic and research excellence. We'll talk about it one by one. The clinical excellence. We are one of the first, we are the first hospital in India to get certification from Joint Commission International. The first ever hospital in entire India to get certification from Joint Commission International, which is the epitome of quality certification in the healthcare industry in India, or rather all over the world. As of now, out of 75 hospitals, 8 of our hospitals are certified by JCI, and all other hospitals are certified by NABH, which is the counterpart of JCI from India. Apart from JCI and NABH, Apollo has its own quality standards, which is called as ACE 25, as you can see. So the quality metrics are really at the best in India. And I think that's a testament that we have patients coming to us from 141 countries. As I just mentioned that Apollo Hospital was the first JCI certified hospital in India. This shows the journey that how we started with one hospital which was certified by JCI, and right now we have 8 hospitals which are certified by JCI. This makes us the oldest and perhaps the only group with maximum JCI certified hospitals in the entire Southeast Asia. Now, another important part is the tender loving care, as I just mentioned, that we consider every patient of ours, whether that patient is Indian or coming from the Arab world or coming from Russia CIS world or coming from any other part of the world, we take care of their cultural preferences. We have translators. We try to have translator service as much as possible, and we take care of, apart from the medical requirements, we take care of their other requirements as well. Another important part is the technology, as I just mentioned. So these are a few examples that we have 320 slice CT scanner, the CyberKnife, and we have telemedicine centers across India and overseas. And the latest one is the proton beam therapy. Again, it's not the latest one. It's been almost 6 years already. We have a proton center up and running. Dr. Srinivas sir will talk about it after this. The latest one after this that we are getting it installed is ZAPEX, which is the non-invasive neurosurgical technology. Maybe by next time when we are here, it would have been already installed. So we can talk about it later. Now, the most important part is the quality of healthcare at the fraction of the cost. The services, the best of the doctors, the highest quality of services being available to the patients at 1/10 of the cost. You compare it with anywhere in the world, the cost in India is more affordable. If I compare, I take liver transplant as an example. If liver transplant is available for $300,000 in US or any other center, say like Singapore, it is available for only $35,000 in India. So it's straight away 1/10 of the cost. Now, these are our centers of excellence. As you can see, we have the heart center, the neurosciences center, the emergency services, the oncology center, and the organ transplant center. As of now, we have more than 7,000 doctors covering 50 specialties across Apollo Hospitals network. As far as the cardiac sciences are concerned, we have done so far more than 160,000 cardiac surgeries. Most important out of them is the robotic cardiac surgery. Perhaps we are the only ones in India right now who have excelled in the robotic cardiac surgery. There is a huge difference between the conventional cardiac surgery and the robotic cardiac surgery. There is less blood loss, there is faster recovery. A patient who comes for a conventional cardiac surgery would take 15 to 20 days to come back to normal life if the surgery is done well. But if it's a robotic cardiac surgery, once the patient is admitted, the patient can be on his toes on the third day. Fourth day, the patient is good to go back home, and the fifth day, the patient is actually back to his normal life. So that's the advantage that the robotic cardiac surgery offers. Moving on, the orthopedics, all kind of joint replacements, robotic joint replacements are being conducted at Apollo hospitals. I already mentioned about the ZEPEX as the latest technology for the non-invasive neurosurgery. Apart from that, all kind of routine neurosurgeries, be that stereotactic neurosurgery or deep brain stimulation, everything is being routinely conducted at Apollo hospitals. Now, very interestingly, we are the pioneer for the emergency care in India. As you can see, there is a 4-digit code. Only very few hospitals in India are provided with this 4-digit code. So because of our vast network all over India, any emergency service can be provided at a very quicker pace with the help of Apollo hospitals. Proud to share that right now, as we are talking, the MotoGP race, if you are aware, is being conducted in India right now. And Apollo Hospitals is the official partner for the MotoGP race in India. We are the only ones to provide the emergency care service for MotoGP in India. Very interesting fact before I move on is the air ambulance. If there is any patient in India, in remote regions or overseas, if there is a requirement, an air ambulance can also be provided to evacuate the patient to any tertiary care center of Apollo in India, be that from Georgia. Very important factor is the bone marrow transplant. As you see, we recently celebrated 10,000 plus bone marrow transplants in India. The first bone marrow transplant for leukemia was also done at Apollo hospitals. I already spoke about the solid organ transplant program. The solid organ transplant is like the liver transplant, the kidney transplant, or the cadaveric heart and lung transplant. As I mentioned, so far we have already conducted more than 4,500 liver transplants and more than 19,000 kidney transplants. The first ever pediatric liver transplant was done way back in 1987 or 1986. That child, his name is Sanjay. Now that's boy Sanjay, who was operated as the first pediatric liver transplant of India, has now grown up to become a young man. He's now a doctor, and now he's working with Apollo hospitals. So that's a testament of the success rate of the pediatric liver transplant. Out of 4,500 liver transplants, almost 500 are the pediatric liver transplants that we have conducted. So these are a few images of few of our hospitals. That's how it looks like. That's how the interiors of the hospital look like. Very interestingly, that Apollo Hospitals is one of the verticals under the Apollo group. We have many other verticals: education and research, medical insurance, Apollo Pharmacy. So there are many other verticals like that. But today I'm here to represent about Apollo Hospitals. So how we collaborate with hospitals, with doctors overseas, outside India. We conduct regular education programs. We conduct regular training programs for the doctors, whether in India or overseas. Or if there is any patient that needs to be followed up, that patient can be followed up either through telemedicine or through visiting that location. Our senior consultants, they travel along and they do the consultations for the patients. You see that Apollo has telemedicine centers all over the world. Right now, we are managing 150 teleclinics across 19 countries, including like in Colombo, Dhaka, Lahore, Maldives, Lagos, Nepal, Yemen, Sudan, and Kazakhstan. You can see President Clinton inaugurating one of our teleclinic centers, along with the chairman, Dr. Pratap Sidedi. Because of the services that Apollo Hospitals has provided and being the pioneer of healthcare services in India, the government of India has issued the postal stamp commemorating the prowess of Apollo Hospitals in healthcare services. This is our team, and Apollo Hospitals has been awarded with multiple awards over the years for like liver and kidney transplants, the cardiac surgery, and oncology at multiple platforms. Well, from my side, that would be all, and I would welcome now Dr. Srinivas Chilikuri, who is the Senior Consultant for Radiation Oncology from Apollo Proton Cancer Center, to talk about the prowess of proton beam therapy. Sir, please. Thank you.
Yeah. Good morning or good afternoon. I don't know what the time is exactly.
11:30.
So not yet good afternoon. So good morning, everyone. And again, I reiterate my colleagues' acknowledgement. Thank you all for coming on a Saturday morning. I'm sure you have many better things to do, but thank you for joining us. And it is my pleasure to share our experience on proton beam therapy, which is a unique piece of technology which we have been using for the last 5 years. And I'll share some of our experience. And I know, I just want to ask a question before I start. How many of you are doctors? Can you have a raise of hands, please? Okay, majority of you are. Okay, because based on that, I'll change my presentation, and thank you for that. Let me start by introducing my center to all of you. This is Apollo Proton Cancer Center. It's Gaurav showed you there are multiple hospitals in the Apollo system, ecosystem. And this is the flagship cancer center for Apollo. Apollo has about 14 different cancer centers across the group. And this is probably the flagship where the patients from various other Apollo hospitals, not just Apollo hospitals, but other hospitals, patients, very challenging cases, complex ones, are referred for to this center, not just for protons, for second opinions, for situations which are a bit of complicated, complex ones. These are referred here. We have multidisciplinary tumor boards on a daily basis. Some of you, if you are keen to join the tumor boards online, you are free to join, because we do deliberate a lot of things during these MDTs, based on which the patients are decided the line of management and therapy, etc. So I come from Chennai. Of course, Apollo Hospitals is there across the country, but I come from the southern part of India. India is a big country. It's probably the 7th largest country in the world based on the area, but the most populous country in the world right now. We have overtaken China. I don't know whether it's a good or a bad thing, but we have overtaken China as the most populous country. But this is where I come from. Not too far. I have never visited Georgia before. This is my first visit to Georgia, but it's not that far, because I can, you can have a direct flight now from Tbilisi to New Delhi, which is the capital of India, and then it's about 2 hour 15-minute flight from New Delhi, which is somewhere here, to come to Chennai. So I was in the morning today, when I was putting up these slides, I was thinking, let me compare the cancer scenario between two countries, which is India and Georgia. And India, of course, is a population of close to 1.3 billion. The population of Georgia is about 3.9 million, which is in the order of 100, maybe 1,000 divided by 1,000. So it's quite significantly less populated. But more importantly for me, we see about 1.3 million cancer patients every year, new cancer patients. And Georgia sees about, you are not able to see it, but 13,181. So about close to 13,000 cases are new cancer patients are added to the cancer kitty every year in Georgia. And I'm sure there will be some who would be undergoing some treatment as well. So at any point of time, there would be about 33,500 cancer patients living in Georgia. So patients with cancer, right? And the mortality figures is about 8,000. So you can see 8 out of 13,000 is the mortality every year. We also have a very similar mortality, by the way, 82,000, 85,000, in fact, 8,51,678 among 1.3 million. So roughly the same number you can see, only divided by 100. You divide it by 100, you see the same result. So if I also looked at the common types of cancer which we treat. Again, very, very similar among women. You can see breast, the pink big pie chart. Breast is still the predominant one. I don't know if you're able to see it, but ours, we have cervix uterus, uterine cervix, probably because of high incidence of human papilloma virus. Instead, you have colorectal, ovary, and others. We have head and neck and ovaries, of course. So ovarian and breast were very, very similar in kind of the distribution among all the cancer patients among women. Among men, if you see a lot of lung in the case of Georgia, we have a lot of head and neck cancers, many, many more compared to lung. You also have a large chunk of prostate. Prostate does not figure in the top 5 cancers in our country. Prostate is probably among the top 10 cancers of the country, more common in urban cancer registries. India is a big country. India is a very heterogeneous country. So if you land in a rural India, it would be extremely, poverty stricken, very, basic things available there. But if you go to a city, you will have all the advances you see in maybe the best of the developed world. So it's a very heterogeneous country. So therefore, the incidence of cancer, the types of cancer we see in different regions also vary significantly. As I mentioned, India is making rapid strides, and we are the most populous. We are also the top 5 economy of the world. In fact, if as per the right calculations based on the purchasing power parity, we are almost there with very close to Japan. But if you just take the numbers, GDP numbers, we are top 5. In 2027, which is about 3 or 4 years from now, we will be overcoming Germany and Japan, and we will be the top 3 economy of the world based on how we are growing, our economy is growing. So therefore, I think we have some amount of technology adoption which has taken place. Healthcare is now become a bigger and bigger priority, as it should be. Till now it wasn't. Now the country recognizes that a population should be more healthy, and therefore the government focuses on healthcare much more than before. So let me start my presentation by telling you a story. This is a child. It is, the child is, the girl is being held by one of my students. This was about 8 to 10 years back. This child had a brain tumor called medulloblastoma. It's a tumor in the posterior fossa of the brain, behind the brainstem. And the child came to me after surgery. So We saw the child had some neurological issues, was unable to walk. We said, okay, let us start some neurorehabilitation with the child. The surgeon already had sent them to neurorehabilitation. The child almost had no tumor left in the posterior fossa, but it was a very good excision. And the child ideally required a course of radiation therapy and chemotherapy. The child received both of them, one after the other, which is the appropriate treatment. And today, as I report about the child is completely disease-free, which is a very happy thing to say. But there's a twist to the story, because the child is not going to regular school because she's unable to focus and learn, unable to walk, still unable to walk. She was unable to walk even then. Even now, she's unable to walk. The growth is stunted. There are many endocrine deficiencies, hormonal issues. There are skin changes, hair changes, frequent infections. She's obese, and she has major psychological issues, and her main enemy is her sister, her own sister. Why? Sister is able to go to school, have friends, is able to dance, play, have fun, has a long hair, and she doesn't has any one of them. So this is a very humbling story to all the physicians, especially those who treat children, that although we have contributed towards the cure of the child, we haven't made the child any better. And clearly we need to do better than this. This is what we offer to the child is and was the standard of care for that day. Even today, if a child is diagnosed of a medulloblastoma in Georgia, this treatment would be considered standard of care. And yet you can see what are the effects of treatment. And now, of course, there is a great emphasis on all of this. This is a landmark paper from St. Jude's Hospital, St. Jude's Children's Hospital in Memphis. And they saw there's a huge burden of medical issues after treatments for cancer, for children. These are childhood cancer survivors who have survived for 20, 30, 40, 50 years beyond their treatment days. And you can see that not just in children who required radiation, those who required only chemotherapy also had a large burden of medical issues. Second cancers, heart issues, renal issues, hematological issues, ocular issues, fertility issues, pulmonary, endocrine, musculoskeletal, neurological, reproductive, infection, auditory, etc., etc. And these are excluding all the psychological issues and social issues. That means, is a child able to get an employment? Is a child able to get married? Is a child able to earn a living? These are, I have not counted those. So these are only medical issues. So clearly we need to do better. Fortunately, with radiation is one of the most cost-effective ways to treat cancer. This is a paper clipping published in 18 July 2023, about a month ago, and I saw that it's very catchy. Radiotherapy is the closest thing to a silver bullet. This is a newspaper from United Kingdom. And the paper mentions that radiation contributes to 4 out of 10 cancer cures. So it's a major treatment. I think you should pat the back of your colleague radiation oncologists if they are, because they are doing a great job, because they are contributing to 4 out of 10 cancer cures. And the paper clipping says that it's the most cost effective of the 3 main treatments: surgery, chemotherapy. It is the most cost effective treatment. And the typical cost per cure, this is of course in UK's context, is 3,000 to 7,000 pounds. And radiation has changed from the days of the situation where you can see on the left-hand side of yours, where the tumor as well as the normal tissue, assuming that the horseshoe-shaped target is a tumor, the central structure is the normal structure. You can see that the normal structure and the tumor are being irradiated to the same dose, no difference. But you see this is the IMRT, where you can see that the tumor is receiving the high doses, but the normal tissues are being spared from the effects of radiation, lesser doses of radiation. But is it enough? Is the normal tissues are still receiving a lot of radiation that contributes to the toxicities, the side effects. So there are next generation advances beyond this in all fields of medicine. I think robotics is one of them. Artificial intelligence, big data is important, probably not yet there. It is going to come soon. Oncogenomics, yes, we are using genomics in all cancer patients. Immunotherapy, I'm sure you have heard of immunotherapy. It's in many solid tumors, it has revolutionized how we treat, in fact, even hematological disorders, immunotherapy. Of course, a new addition of immunotherapy, CAR T-cell therapy, is also being used. Precision medicine, which is personalized medicine, and modern proton therapy. I think these are some of the key advances. And if you are an oncologist, if you are a physician who occasionally sees cancer patients, or if you are an individual who who may have a cancer patient in the family or friends, and we all have one in our extended families, if not our own. We need to know all these advances because these are going to revolutionize how we treat cancer patients in the next few decades. And there are phases of adoption of technology. And you can see that there are early beginners, we call as innovators, early adopters, early majority, late majority, and laggards. So always technology goes like that, and proton therapy is also going through the cycles of new technology diffusion of innovation models. Let me talk about proton beam therapy, what it is, why is it so revolutionary technology, why is it good, Essentially, when I say proton therapy is very good, I am comparing with conventional radiation therapy, which is X-ray based radiation therapy. X-rays, they enter the body and they deposit most of the energy just beneath the skin, and they get attenuated. That means they lose their intensity as they travel across the body. And therefore, you can see the gray curve enter the peak dose after they enter the skin, and you can see the gradual fall of the intensity. Protons, they enter the body, like they enter the medium, they deposit their entire energy after they travel a particular distance, and then deposit their entire energy and drop dead. Literally, you see that this is the proton beam therapy and this is X-rays, wherein the X-ray beams do not stop, the protons stop within the tumor, and therefore you deposit very, very focused energy. And if you don't give dose to the neighboring structures, what happens? Theoretically, there is no or less toxicity, and you can increase the doses to the tumor, etc., etc. So what is the modern proton therapy? I was talking to some of my colleagues here in Georgia yesterday in the evening, that essentially we are delivering these black peaks into the tumor spot by spot, layer by layer, from the deepest to the most superficial layer, and we are targeting the entire tumor. And not just proton beam therapy, there is a proton and there is a proton. And what I am talking about is the most modern proton beam therapy with image guidance, cone beam CT, Monte Carlo algorithms, small spot sizes, good planning systems, possibility for motion management strategies, etc., etc. So there are many intricacies to the typical proton beam therapy, what we see, and what we have currently is the most modern proton beam therapy one can have. And this is the distribution. I mean, this is a sacral lesion adjacent to the rectum. You can see that this is the VMAT distribution. You have one such, IMRT equipment in Georgia as well, many, I don't know how many, but you have few of them. And this is protons, and you can see the difference. The rectum, the majority of the rectum, this is the rectum, by the way, and this is being spared beautifully from any dose of radiation, and bone marrow, the bladder, etc., etc. So just an example to show that we are able to spare normal structures. If we spare normal structures, there is very little toxicity. So not just physical advantages, but there are theoretically biological advantages as well, that tumors that are resistant to conventional treatments, conventional radiation, can be more damaging by protons, because there is slightly higher biological effect, and we quantify that as radiobiological effectiveness, which is about 10 to 50% more or higher with protons. So you see the difference. This is a patient whom I was talking about, where you need to give brain and the spine. This is with conventional radiation. This is with protons. You can see patient's gonads, kidneys, bowel, heart, lungs, oral cavity, thyroid, everything spared. No dose, zero dose to the normal structures. Similarly, look at a mediastinal, a lung tumor. You can see that is protons, and this is conventional radiation. You can see a lot of normal tissue irradiation, the heart, the lungs, and the breast, etc. Similarly, prostate, you see the brain as well. You can see this is the protons, and this is conventional radiation, where you have all the low doses going to the rest of the normal brain. So based on the physical and biological advances of protons, there are multiple advantages in almost all sites, right from pediatric, thoracic, prostate, sarcomas, head and neck, brain tumors, GI cancers, etc., etc. So this is the room in which it is being treated. Because there is an advantage, can we use it for every patient? Answer is no, because this is a huge piece of technology. You can see that, he's standing there, a 3-storied, gantry. This is a large beam transportation system, maybe bigger than this room, through which the beam is transported. The cost to set up is 15 times higher. Initial setup, the cost to maintain is 12 times higher. The electricity cost, the throughput, the manpower required, everything is much, much higher with protons compared to conventional radiation. And therefore, we need to know where to use it. We cannot be using it for every patient. And therefore, I am here to educate my colleagues and friends where these patients can be benefited, where which patients can be benefited. And there is increasing recognition that there is a higher number of proton centers across the world, and you can see the graph going exponentially higher. You can see now in majority of the European nations are investing in proton therapy technologies. US, each state has one. Many countries are going to have proton therapy facilities. I've heard that Egypt is going to have one. Israel recently has started one. So there are many neighboring countries, around who will eventually start proton therapy facility across this part of the world. So just to reiterate again, there are certain patients in each of these cancers: pediatric, lungs, GI, bone and soft tissue, rectal, anal, prostate, breast, liver, head and neck, and CNS tumors who could benefit with protons. I think I will share these slides with you so that you can dwell deep into this particular aspect. So there is a number of data to support use of protons. This is one of the publications published in Journal of American Medical Association, JAMA Oncology. And this is a comparison between proton and conventional radiation along with chemotherapy. Patients who received protons reached faster back to work. The disability was lesser, etc., etc. So there is data to in the context of head and neck and lung cancers. There are now many randomized trials in breast, in glioblastoma, which is a brain tumor, lung cancer, prostate cancer, esophageal cancers, liver cancers, low-grade gliomas, high-grade gliomas, head and neck cancers, etc., etc. So there are randomized trials which are undergoing right now across the world. So where do we use protons, where the tumors are in close proximity to any critical structures and results in underdosing. So you have skull-based tumors, paraspinal tumors, pancreatic tumors, retroperitoneal tumors, chordomas, brain tumors, wherein the tumors are in very close proximity to critical structure. And therefore, you would recommend protons. There is another situation where increased clinically meaningful normal tissue toxicity with photon techniques. Like if you give radiation to child, you will have more toxicities. There you can reduce the toxicities. It could be benign brain tumors, pediatric malignancies, head and neck cancers, esophageal cancers. There are situations where photon plans, conventional radiation plans, are prohibitive. That means the oncologist says, I cannot give radiation. There also you could consider protons. And of course, re-irradiation. That means if any patient is receiving radiation for the second or third time, definitely one should consider protons. So there are many ways to select protons. I will not go into details, but there is some kind of a guidance statement, and I will enumerate some of the indications as mentioned as per the model policies of American Society of Radiation Oncology. Spinal tumors, chordoma, chondrosarcomas, pediatric tumors, liver cancers, hepatocellular cancers, patients with malignant or benign tumors of brain, advanced head and neck cancers, cancers of paranasal sinuses, non-metastatic retroperitoneal tumors, sarcomas, and re-irradiation. I will just repeat whatever I said. Chordoma, chondrosarcomas, pediatric tumors, brain tumors, advanced head and neck cancers, paranasal sinus tumors, non-metastatic retroperitoneal sarcomas, and re-irradiation situations. So these are the standard indications of proton beam therapy. There are new emerging indications of protons: left-sided breast, high-risk prostate, thoracic malignancies, lower lobe lung cancers, resectable head and neck cancers in the post-op setting, etc., etc. So evidence generation is extremely important. Whatever evidence we have, we are extrapolating from, say, United States, and therefore we decided very early that for Indian patients, we will generate our own evidence, our own data. So this is one of my publications in radiation oncology, where we have a commentary on how to generate evidence, and we are following some of the principles which I mentioned. We are now running several prospective studies. These are in public domain. These are Cancer Trial Registry of India. They are all in the public domain, so anyone can access it. So it is for prostate, for pediatric, for bone and soft tissue, elderly cancers, thoracic and abdominal moving tumors, breast, brain, and liver tumors. We are running prospective studies now. So I will give you a snapshot, a brief snapshot of our experience. 4 out of 5 patients, that means 80% of patients belong to these 4 categories. 1, brain tumors. 2, children. 3, head and neck and skull base. 4, musculoskeletal and bone and soft tissue. So these are our top indications. In fact, 80% of patients belong to these 4 categories. And of course, there are some prostate, some breast, some head and so gynec, some thoracic, etc. So just to give a snapshot of our experience in pediatric, you name it, we have treated almost all cancers in pediatric age group, whether it's intracranial or extracranial. I will not enumerate all of these, but this is our distribution. There are many key benefits. I have already mentioned that all late effects are dose dependent. That means higher dose received by normal tissues, higher is the chance of side effects. And if you do not irradiate normal tissues, you do not have side effects. So this is the basic principle, and you can see that if I'm treating a child who has a perineal rhabdomyosarcoma, the parents come to me and ask me, okay, what are the long-term effects? I would say yes, the chance of cure is very high, 80-85%, but the child may not have normal sexual function. Why? Because I'm irradiating a little bit of vulva, vagina, etc., etc. But with protons, you can see that I'm sparing all of these structures and I can be reasonably sure that the child is likely to have a normal sexual function. So these are certain examples based on which you would say in pediatrics it is probably the best indication for proton beam therapy. The summary of benefits: reduction in neurocognitive decline, preservation of neuroendocrine function, less organ dysfunction, bone marrow, heart, lungs, salivary glands, preservation of fertility, lesser probability of second cancers, and last but not the least is improved quality of life in children. This is a paper from our group, from myself and my colleague, which is published in Neuro-Oncology, one of the very reputed journals. We also presented our data in this, published our data 2 years ago. This is very preliminary results of about 50 children treated at our center. And we have treated almost all childhood cancers. We also have published our experience of using craniospinal radiation, our early experience in treating these children. We have also published our clinical audit for medulloblastomas and patients receiving CSI in another paper as well. So a lot of publication coming from pediatric tumors. But this is just a case example. This is a 12-year-old child. I'm not sure whether there is a hemato-oncologist here, pediatric hemato-oncologist. But this is a 12-year-old child, had a history of acute myeloid leukemia, received bone marrow transplant not once but twice, cured of that, controlled. Almost 5 years later, developed rhabdomyolysis sarcoma of a very odd location. You can see it's near the diaphragm, very close to the heart, very close to the liver, stomach, etc. This is the tumor. And we treated, of course, after chemotherapy, initial course of chemotherapy had a very good response. And sparing the heart quite well, and almost low doses. Whatever you see, the low doses are very little in the heart. Similarly, we have treated a number of brain tumors, germ cell tumors, ependymomas, pediatric low-grade gliomas, etc. And there is now a randomized trial between IMPT and IMRT, which is proton therapy versus IMRT. And hopefully that will answer it will establish the role of proton in pediatric low-grade gliomas. Coming to head and neck cancers, again, we would put patients into 4 categories. One is skull-based tumors, paranasal sinus periorbital tumors, re-radiation, and mucosal sparing head and neck cancer treatments. So this is one of the patients, 65-year-old, ICD in situ, ejection fraction 20%, diabetic, loss of vision, right eye, proptosis, moderately differentiated squamous cell carcinoma. You can see the huge tumor. And, we treated this patient. You can see the tomotherapy plan and proton plan. You can see the difference, the conventional radiation and proton. And huge difference, and there was complete response after 8 weeks of post-proton therapy. Very gratifying result. Adenoid cystic cancer of lacrimal gland, very difficult site because of the eye, needs large doses of radiation. We treated such patient, again, complete response. Salivary gland tumors in young adults, huge difference, again, with proton beam therapy compared to conventional radiation. You can see the 2 pictures, very, very obvious. This is conventional radiation on the left, right protons, all the contralateral mucosa completely spared from the effects of radiation. And you can see at the end of 26 fraction, you can see the mucosa is looking as clean and fresh as a normal healthy mucosa. Similarly, a large chunk of musculoskeletal tumors we have treated, chordomas, chondrosarcomas, Ewing's, osteosarcomas, soft tissue sarcomas. I treat this site as well, and very gratifying results. One of our early patients, you see a huge tumor, and after protons you can see the serial shrinking of the tumor. As we we followed up this patient after proton beam therapy, and you can see how small the tumor has become, and the patient is able to walk with a limp, occasional analgesics, and is doing very well. Similarly, pelvic osteosarcoma, huge tumor in a young child. We spared bowel, ovaries, and pelvic structures, received concurrent chemotherapy, which is not typical for osteosarcomas, and during radiation, and the child is doing very well. Even patients who had osteogenic sarcoma with tumor thrombus, we treated the tumor thrombus as well, and that resulted, you can see the tumor thrombus also being treated, and the patient is actually doing very well after 2 years. You can see the tumor thrombus also completely showing very good response. This is a very interesting case. This patient actually came from United Kingdom. 63-year-old gentleman with squamous cell carcinoma of left lung, T3, N3, M0, diabetic, hypertensive, weighing about 120 kgs. He was using occasionally oxygen. This was a PET scan. You can see left lobe lung lesion. The patient was planned with IMRT in UK, in Sheffield. It was quite a good plan, no problem with that, but the V20 was 36%, V5 was 62%, mean heart dose of 30 gray in an obese patient is possibly not acceptable. Patient is on oxygen occasionally. It's a prohibitive plan. The oncologist said, okay, it's too much of radiation. Now let's give chemo first, shrink it, and then let's go for radiation. They did the chemo, hardly anything shrunk. And what to do next? Then the patient contacted us for proton beams because the UK was not yet treating. In fact, even now, they're not treating moving tumors. We were treating moving tumors. So the patient traveled from UK to India, treated with, first of all, planned with, initially the UK doctors, they were circumspect. Will proton therapy really benefit? Let me send you the plan. Just send me a plan how good it looks. And we showed them the plan. That is proton and this is conventional radiation. And you can see that the hard dose came from 30 gray mean dose to 7 gray. The V20 came down from 36% to 22%, V5 62% to 35%, 20 gray mean lung dose to 12 gray. So the probability of grade 3 toxicity is significantly reduced. As soon as we sent the plan, even before the oncologist responded, the patient saw the comparison by himself and he traveled without any information to us, landed up in Chennai and said, I need protons, and we treated him. It's been now nearly 2.5, 3 years. He's still in touch with me. In fact, in the morning, he every day in the morning, he sends me a good morning message. And you can see complete response. This is in March 2022, of course, but even today he's disease free and he's become one of our big ambassadors for proton therapy in United Kingdom, in Europe. So these are some of the key case example which I can share. Similarly, this we publish in Proton Therapy. Of course, for prostate cancers, not all patients require protons, but there are certain patients, high-risk patients, where we think there is a benefit of protons. There is also a situation where protons could be used in patients with poor baseline IPSS scores, poor baseline neurological scores. Long-term outcomes, sexual outcomes are also have been shown to be better with protons compared to conventional. So if a patient is young and wants to preserve sexual function, slightly better than conventional radiation, proton could be an option. We are looking at treating only 5 fractions as well, including the dominant intraprostatic lesion. We are escalating the doses in protons. and we are treating them only with 5 days. The cost also significantly comes down, the stay comes down significantly, therefore we are treating these patients with 5 fractions. This is esophageal cancer patients. There is now a randomized trial which compares photon versus protons for esophageal cancers, and it has shown that reduced toxicities with protons was found in patients. Similarly, we have treated a large number of liver and liver tumors. Some pancreatic tumors also have been treated to very good results. So coming back to the question, I think I tried answering all these questions. Where is proton therapy useful? I've given some kind of an example. I cannot generalize it. I cannot say that yes, in these cancers proton therapy is not useful, but in each case you need to be a bit nuanced and understand whether there would be any benefit, whether is it cost effective, whether the patient can travel. There are certain group of indications where proton therapy is really beneficial, but there are some where the benefit is substantial, not very small, but it all depends on the logistics and the patient's preferences. So this is a publication. India is also a low and middle income country. As I said, India is of course one of the top 5 economies of the world today. But having said that, India is also a poor country. And India has its own set of problems. So proton therapy in low and middle income country, is the need justified? Is it really required? This was a commentary I published 2 years back in Journal of Clinical Oncology, Global Oncology. And what we wrote is that proton therapy is an engineering marvel, which is certainly of great benefit for a few patients, incremental benefit for some, and maybe of not much benefit for many. We will, and the medical science will continue to evaluate this technology to unravel this mix, but patients who are likely to benefit with this technology, irrespective of country of their residence, must be able to access this relatively easily and at a reasonable cost. And the same thing was proposed yesterday to some of the your Georgian ministry colleagues, and I'm happy to hear that they're already looking after children who really deserve proton beam therapy as recommended by the oncologists of Georgia. They are supporting the finances to sponsor their treatments abroad, and it's extremely good to know that the government of Georgia is helping these children, and I'm sure there will be many other patients who could benefit from this particular generosity. And what we also mention in our paper is access versus timely adoption of modern technology are both equally important, and they should be parallel goals and not mutually exclusive. We cannot say that unless we provide food for everyone, we cannot build big things. We have a lunar mission. We recently landed on the dark side of the moon. There are patients, there are situations where the infrastructure is poor in the country, but we cannot say that unless the infrastructure is provided, I will not go to the moon. And both have to go simultaneously. We need to improve infrastructure. We also need to go to the moon and explore the future. So to conclude, we have treated more than 1,000 patients. We have got a very promising early experience. Multiple sites have been treated. Data is being collected prospectively. We have published quite a number of papers, about 60 of them. Low rates of acute toxicities, large percentage of recurrent re-radiation patients. As the footprint of the technology comes down, it becomes a smaller and smaller piece of technology. The cost is likely to come down, and hopefully we are seeing patients from 6 continents. We had patients from Chile as well recently, not recently, about a year back. Now there are a few patients coming from Chile as well, which is South America, very, very far. Georgia is relatively much, much closer. So if there are any deserving patients who could benefit from protons, you could consider Apollo Proton Cancer Center as one of the destinations. And with this, I would like to conclude my talk and would be very happy to take any questions.
Thank you for nice presentation. My question is regarding those constraints. Since proton beam therapy is a safe treatment, how different are those constraints? And could you please demonstrate on, for example, head and neck radiotherapy?
So more or less the constraints remain the same, but there are certain critical constraints which are slightly different. So for example, the spinal cord constraint would remain largely the same. The brainstem constraint in children would be slightly lesser than what we usually give. And overall, the constraints are very, very aspirational. That means you would say, okay, pharyngeal constrictors less than 50 gray. But if we can achieve less than 25 gray, if we say to tell our physicists who are planning, okay, let me give the constraint less than 50 gray, they achieve 40 gray. But if I give less than 25 gray, they achieve that also. So it is more of aspirational constraints, and we push ourselves to understand. Even in prostate, I treat prostate as well, and the constraints are much better than what I use, a chip trial constraints, what we use routinely in many, many clinical situations. I stretch it significantly to maybe 50-60% less. So that way constraints, the critical constraint more or less remain the same, but most of the constraints are aspirational.
Okay, thank you very much.
For anyone who would like to visit the Proton Center, we will be happy to welcome any of you who wishes to come to the Proton Center to see how we work, what we do there. With that, I would probably hand over mic to my colleague Amit.
Good afternoon, everyone. And thank you for taking time to come here. And I welcome everyone to come to India. We are also trying to change the Georgian perception of India, you know, our healthcare system, as you see, the doctors and expertise. So together with ACA and Medical Linkers from where I am, we would like to welcome anyone who wants to see our facilities and would like to, some residents who would like to see, and the doctors who need training in India, we all, you know, welcome with warm hands. So from this platform, I take this opportunity to invite you all to India and to see our hospitals anytime you prefer. You can contact us and we'll get that arranged for you, right? Thank you for everyone for joining in today. And if you have any questions further, we have time, you can still ask, right? You have anything to say? Yeah.
Thank you, Amit. Just one more point, which could be very instrumental, is that, I mean, like, since we spoke about the Proton Center, would want to ask Sir if he could highlight on the cost for proton therapy, sir.
So the cost of proton therapy is a bit of a complicated thing because it's not very straightforward. So it ranges somewhere between $25,000 US to $55,000 US. It depends on the complexity of the case, the requirement of anesthesia, requirement of admission during protons, number of fractions, number of sittings, etc., etc. But usually the children are treated at slightly lesser cost compared to adults. So there are many intricacies. So I would, approximately between 25 to 55,000 US is the cost of the treatment.
So I would want to ask further question to the same thing, that if there is a patient who is needing proton therapy treatment, but then certainly there would be more ancillary services that would be needed. So how would that impact the cost?
So typically if a patient is coming for protons, the patient may require, say, concurrent chemotherapy along with radiation, protons. Patient may have an infection. Patient may require antibiotics. Patient may require admission to ICU. Patient may have a small procedure required. Patient may require, say, elderly patients may require dialysis. Patients require, various kind of support. Maybe a cardiac issue. You need to sort that out first before we start the treatment. Sorting out a cardiac issue, or giving antibiotics, or admission to the hospital would cost a lot more in other countries compared to India. It would be much, much cost effective. So in that sense, if you look at proton therapy, it is an expensive treatment. But if you look at other treatment options, like simple consultation with a nephrologist is a lot more cheaper. You probably can see a nephrologist in India, for a good nephrologist in India, experienced nephrologist in India, for maybe $20. So which is very good. The drug costs also significantly less. India is a pharma hub for the world. Half the drugs, half the chemotherapeutic drugs, half the analgesics are manufactured in India and supported, for example, in US, 50% of the market is Indian pharmaceutical supported. So in that sense, generics are available, the cost comes down significantly. So it is a benefit for patients where, always it's a cost is an issue. So that becomes a lot more cost effective to be treated in India compared to other countries.
I would just want to add one more thing to the cost factor. So, yeah, Apollo Hospitals is a private hospital, fully private hospital. Yes, so we work towards the profit, no doubt. But at the end of the day, we never deny the treatment to a patient. If there is a patient who needs the treatment but is unable to afford, there are ways and means where we try to raise the fund and we try to help the patients for highly critical illnesses. So if there is any case, either way, just let us know and we'll be glad to assist in any which way possible. Ms. Ika would be a single point of contact here. Second thing, which is a very great news, recently I believe there is a direct flight that has started between New Delhi and Tbilisi. I believe that it's almost every day in a week. Yeah, so 7 days in a week. So we are just 4.5 hours away from Tbilisi. So that's a good news. Anything from your side, we are happy to answer any question, please.
I have one question.
Yes, sir, please.
I'm just wondering, looking at the photo, it looks like EBA Proteus 1 machine. So what kind of machine do you use in your...
It is IBA.
So you use IBA?
Yes.
1 gantry EBA?
No, 3 gantry.
You have 3 gantries. Okay. And are you doing uveal melanomas?
No.
Thank you very much.
Uveal melanoma needs a dedicated eye line.
Yes.
In our country, melanomas are very rare because it's more popular, more common in Caucasian population, so we are not treating melanomas.
Thank you.
In fact, I forgot to mention it. In fact, I didn't put in my slides that if tomorrow Georgia buys an IBA proton therapy machine, you will be given 2 options for training before you start. One is Apollo Proton Cancer Center, and the other is University of Pennsylvania in Philadelphia. So these are the 2 recognized institutes for training on IBA equipment. So we are one of them. In that sense as well. So we are a training center for proton therapy, both from the physician side, the physicist side, the therapist side, and even the administrator side. They come for training at our center.
Thank you. Thank you for our guests, for your presentation.
There's a question.
Okay. First of all, thank you for your very interesting presentation and for sharing your experience with us. So my question is about dose, okay, as we see huge advantage of proton therapy is that patient receives lower doses to the organ at risk, right? So my question is if we give same dose to the tumor, same as when we give during photon therapy, or are we able to give higher doses to the tumor? And if not, why are we not giving this higher doses?
So very good question. I agree with your question that if we are able to give a higher doses, we should be giving higher doses. But we also need to answer that question that are higher doses better? Dose escalation has not been proven in all sites to be better. So, but I'm dealing with a sarcoma, a chordoma, or a chondrosarcoma, where we know that higher the dose, better is the outcome. Definitely we go up to 74, 76 gray of radiation in a large chordoma, very close to brainstem, very close to the spinal cord. We go up to 74, 76 grays. Similarly, there are many situations where we are escalating doses, even in head and neck cancer, some of them we go up to 72, 74. Post-operative doses are typically 60 gray, right? But we go up to 66, 70 routinely in patients who have extraneural extension, perineural invasion, etc. WOPI, that is worst pattern of invasion, type 5, we are escalating doses to slightly higher doses. You are absolutely right. We are not doing that routinely in all patients because there is no evidence for dose escalation, and I cannot just randomly treat patients with the doses which I would like. But in situations where we know that the outcomes may not be very good, we try to escalate the doses. That's a good question. Thank you.
Thanks.
Sorry, Eka, go ahead.
Okay, thanks a lot. More important also is in ahead to have the lunch.